What a field day for the heat down there. 1,000 people in the street singing songs and they carry inside. Mostly saying hooray for our side. These battle lines being drawn. Nobody's right if everybody wrong. When people speak in their mind, getting so much resistance from behind. We got to stop the children, what's that sound? Everybody look, it's going down.
Hello, everyone. This is Lauren Steiner, and welcome to this afternoon's special edition of The Robust Opposition. We're here to talk about how to meet this moment of a global pandemic with Medicare for All. We've got a lot of other stuff to talk about, but I want to introduce my guest. Paul Song is a friend of mine here in Los Angeles. He's a radiation oncologist by profession. He also has his finger in some biotech companies, but he is the president of the California chapter of Physicians for a National Health Program, which advocates for Medicare for All. And Wendell Potter, as a famous insurance industry whistleblower, he used to do communications for Cigna health insurance company until he saw the light and then started fighting for the good side. He also started a online publication, investigative journalist publication called Tarbell. And he is heading an organization called Business For Medicare for All. Can you guys each talk about what has been your involvement with the movement for Medicare for All? And let's start with you, Paul.
It's good to see you, Lauren, and great to see you, Wendell. I will say that I've been involved in really advocating and educating for Medicare for All for probably the last 15 years of my professional career. A lot of this was born out of my own frustrations as a practicing radiation oncologist, seeing so many of my own patients who were having such difficulty in a cruel and inhuman system. Many of them were insured and finding themselves on the brink of financial ruin and bankruptcy, despite the fact that they were insured. I also felt that as a practicing physician, it became harder and harder for me to actually treat patients the way I was trained to do. And many times I was spending more time on the phone fighting with somebody from the insurance industry who was sitting there constantly trying to deny and micromanage every aspect of my treatment plan for my patients. So I've been very much involved in this fight for a long time. And in the beginning, it was like a lone wolf barking in the woods. But now you see more and more people coming around to it and embracing this as the best treatment that's out there. So it's been a lot less lonely now fighting for this, particularly with people like with Wendell.
Great. So how about you, Wendell? Why don't you talk about how long you've been involved in this fight for Medicare for All?
Well, now several years, not quite as long as Paul, because I was on the other side for several years, as you noted, for about 20 years for Humana and then Cigna. And I did, after having a crisis of conscience, left my job in 2008, and I began really my advocacy the next year when I was asked to testify before Congress. I had been working behind the scenes after leaving Cigna, working with advocates, and after Barack Obama was elected president, I decided I would go to Washington a lot and just see if I could, again, work behind the scenes with healthcare reform advocates. I ultimately was advised or told that if I really wanted to make a difference, I should take the risk of going public, and I decided to do that. I testified before the Senate, a Senate committee in June of 2009, and then after that, several committees on the House side as Congress was debating what became the Affordable Care Act. And I fully expected to have kind of a worst case scenario after that, because I knew what my industry was capable of in terms of retaliation. But I've been fortunate. I think one of the reasons I've been fortunate, among the reasons, one was first time out before Congress. Secondly, I used to work with the media in my old career, so I know how the media works, and I wasn't intimidated necessarily about doing a lot of media interviews, and I have done that. And also, And I think primarily I've been telling the truth ever since I began my speaking out. And I've written now 3 books, have done many interviews, and as you noted, I've even started my own journalism organization. I don't necessarily have any axe to grind. I don't have an axe to grind with my former employers. What I talk about has been industry-wide practices that I've been aware of and a part of and was for about 20 years. I became really involved in Medicare for All in more recent years, or at least to head up an organization, as you mentioned, Business for Medicare for All, because I became very much aware that not only is our healthcare system a real problem for so many Americans, so many individuals and families, it's becoming an unbearable burden for many employers, and we're seeing that play out right now during this pandemic, as many companies are having to lay off their workers. More people are joining the ranks of the uninsured, and when we emerge from this, we're going to find that employers are going to be really hard pressed to step back in and to provide benefits to their workers like they have in the past. So a lot of what I do is talking about just the fragility, the insecurity of having a system that is based on our employment. I talk about the bad actors in health insurance and why we need to move to a Medicare for All type system. So I'm continuing to be a very vocal critic of the industry.
Okay. So how do you see the industry now trying to profit from this pandemic? Do you see them trying to get out of paying for treatment? And how are they framing it to make themselves look like heroes? I saw an ad on Twitter yesterday on how Humana is suspending all copays for COVID-19 treatment.
Yeah, and it's very much of what I used to do for a living when I was there. Whenever there would be a crisis, I was at Humana during Hurricane Andrew many years ago, and one of the things that the companies will do is come out with a PR initiative to make people think that they're really good guys here. They're watching to make sure that they're not paying out more in claims than they expected, and they can avoid paying claims in many different ways. Even though we've heard many of them say that they're waiving their co-payments and any co-insurance obligations and deductibles, that is not necessarily the experience that people will have. In fact, Elizabeth Rosenthal wrote a piece for the New York Times a few days ago, just pointing out, despite the industry's assurances, people can still wind up with bills that are coming due. In many cases, because of the practices of the insurance industry of limiting our access to doctors and hospitals. Even if you go to an in-network hospital for treatment, there's an increasing chance that you might be treated with an emergency room physician who is not in your health plan's network, even though the hospital is. And many radiologists and anesthesiologists and other doctors are not in health plan networks these days. So don't believe the assurances of these companies. They're going to be trying to make sure that they avoid paying claims as much as they possibly can, and they can do that.
Okay. Paul, maybe you can talk about how the exchanges are stepping up. I know that in California, Covered California extended the enrollment period and stepped up the subsidy. Maybe you can talk about that, and also how this situation is going to affect Medicaid in California.
So a couple things about that. Remember, the exchanges are primarily for people that are between and who are receiving a subsidy support, or people that are making between 138% to 400% of the poverty line. The problem with this, and while it's a great gesture to keep the exchange open, the majority of people who are having to find healthcare because they've lost their employer-sponsored healthcare are, by most part, not even going to be able to afford purchasing insurance on the exchange. That's sort of the fallacy of our employer-sponsored healthcare plan. You know, you had Democrats during the debate saying that you're going to kick 100 million people off their employer-sponsored health plans. Well, we just kicked 10 million people off their employer-sponsored health plan in the last 3 weeks as they've lost their employment. And the majority of these people have a choice, right? After they lose their job, by law, a lot of them are allowed to participate in COBRA, which is an extension of the healthcare benefits they had, but they're responsible for paying into that and many times substantially more than what was being deducted from their paycheck when they were actually employed. So I know quite a few people who have lost their jobs who cannot afford their COBRA payments. They certainly can't afford to go find coverage under the exchange. So a lot of these people will now be pushed into Medicaid, or in California, Medi-Cal. And again, that's another fallacy for, I look at the incrementalists in our state who were trying to push a Medicaid expansion as the answer to our healthcare needs, is that in economic downturns, Medicaid is already overstretched in the state of California, but in an economic downturn where you now have millions of people who've lost their employer-sponsored health care, who are now going to try to get their coverage through Medicaid, you are further overwhelming an overstretched system. So right now, if you have Medicaid in the state of California, it's very hard for you to find a provider that will take you. Part of that is because reimbursement rates are so low. But now you factor into the fact that you now have millions of people in the state of California who potentially will now go from employer-sponsored to Medi-Cal. There's not going to be enough resources or ability to get these people the type of treatment that they need. And this is going to further expose the problems of a Medi-Cal system.
Yes. Now, I read in Salon that premiums for covered California are expected to go up about 40% next year to cover all the COVID-19 related cases. What can you say about that? Either one of you who knows about that issue.
I can speak specifically for California. So as you know, a couple of years ago, we tried to pass an initiative, Prop 45, which would have given the insurance commissioner the authority to really regulate runaway insurance rates. It was soundly defeated as the insurance industry outspent everyone 50 to 1. But the problem is that the Affordable Care Act, the two things, because it was essentially written by the insurance industry and pharmaceutical industry, that it didn't have built into it was insurance rate regulation and pharmaceutical drug pricing control. With regard to insurance rate regulation here in the state of California, the idea that somehow an exchange would keep prices down is simply not borne out. Prices have continued to go up double digits up until last year, since the exchanges were implemented. And again, what Wendell was saying is the insurance industry, they may be forced to pay for some treatment related to COVID-19 right now or testing, but don't think they're not going to try to make it up on the back end, which means in terms of higher premiums next year. So I did see, this was actually a study that was done by Covered California. And what's going to happen is, remember, they have to make up for the losses this year as well as keeping their profits as high as can be. And if they factor this into the norm of where healthcare costs and risks are going to be for the rest of our lives moving forward, they're going to find a way to charge a premium. And so that's why you're seeing the 40% being floated out there. And that is very possible for a lot of people.
It really is very possible for a lot of people, and also not just limited to people who get their coverage through the exchange, as many people do in California. Another thing to keep in mind, though, about the exchange plans, the out-of-pocket obligations are typically much higher for people, and people who are getting coverage for anything other than COVID are still going to be on the hook for paying or meeting their big deductibles. And this is also going to affect people who have employer-based coverage next year as well, too. These companies will be looking to raise rates on those folks as well, too. And in many cases, employers will have no alternative except to pass along not only greater percentages of the premium to their workers, but even make their deductibles even higher next year.
Well, as you alluded to earlier, this exposes the big lie that was used to justify opposition to Medicare for All by all of our candidates, that people love their private insurance plans and should be allowed to keep them. Do either one of you want to expand on that?
Well, I think Wendell has a lot of great takes. I will just say one thing about some of the lies that are being exposed. So one was the number of employer-sponsored people that would be kicked off their roles, which is happening right now as we speak. The second one is the idea that somehow it would take away your ability to see your doctors. It should be pointed out that the private insurance industry, most of us have plans that have narrow networks. What that means is that we can only see about 25% of all the doctors in our geographic area. That 75% of the doctors in our geographic area are not even contracted by the insurance plan that you have your policy through. So somehow the idea that this would limit physician choice is simply not true when the private insurance industry is already doing that to us. The other part I would say is that private insurance is always going to find a way to make money. So when they view paying out, whether it be for COVID-19 or some increased risk of heart disease or cancer, they will find a way to make money. And the way they're going to do it is with the premiums. All of those things would not happen under a Medicare for All plan. And so when I hear Senator Klobuchar, when she was saying everyone's going to lose their insurance, when I hear Vice President Biden saying you can't see your doctors, that's our healthcare system right now. And this is just magnifying and really calling out the lies that they were saying during the debate in a way that, frankly, we wouldn't have seen, because it's hard to really pinpoint their lies. But you're seeing these lies come to fruition in real time because of the rapid nature of our virus.
Yeah, I said essentially the same thing. They were telling lies back then, or they were obscuring the truth if it wasn't an outright lie. And I've said in some other interviews that I would dare any one of those candidates, if we were to have the same debate now, I'm sure that not a single one of them would extol the virtues of keeping the employer-based system. Where, as Paul said, we're now seeing exactly what the consequences are for us to have been sold this bill of goods and buy into it over many years, that we need to preserve the employer-based system. The industry that benefits most from this, by the way, is the insurance industry, because the big companies get the lion's share of their revenues from big employers who are self-insured. And by working with those kinds of employers, this gets a bit into the weeds, but it is actually the employer that is bearing the risk. And the insurance companies command a hefty fee. And so they love it. This has really been a gravy train for them over many years. They love the employer-based system. One of the big trade associations has had this ongoing campaign since we began this last conversation about reforming our healthcare system. Their campaign is called Coverage at Work, and it is trying to persuade the public and policymakers that it's something that needs to be protected. As Paul said, and as I think we're all aware of now, we're seeing the folly of allowing a system like that to go on, in which we're depending on access to care through our employer.
And Lauren, I'd just say what's also ironic is you have now the Trump administration floating the idea that it will reimburse hospitals to take care of uninsured people during this COVID-19 pandemic. And so they've done a 180. They've tried to withhold aid to states and reduce Medicare and Medicaid. And now they're having to go to a full-blown, almost socialized system where they are taking care of all of these hospital bills. And so it's really interesting to see how the dynamic is changing very, very quickly. The other thing that's very important to realize is that in those red states that have either refused to expand Medicaid or put in a work requirement in order to qualify, you have all these people that are losing their jobs because they are in food service industries or in the gig economy, who don't have the employment mandate or requirements to qualify for Medicaid. They get sick, they're gonna further infect their neighborhood because they can't get the treatment or the testing. And this is just going to perpetuate the whole problem with our healthcare system. So when we try to talk about preventative care, public health, it's the idea that you can avoid sort of the back end of ignoring those situations and pay a bigger bill in the long term. And that's what we're going to end up doing now.
Yeah, I want to ask you, that was actually going to be my next question, if you think that having Medicare for All would have materially affected the scope of this crisis. I mean, would there have been more or earlier testing Would more people have come in earlier to get treated? I even read about Germany that their deaths are fewer because they treat people before they need to go on ventilators. And apparently, once you go on a ventilator, 80% of people do not make it.
So a couple things I would say about that is you heard Vice President Biden during the debates use Italy as an example of why Medicare for All wouldn't work. And then you have Korea, on the other hand, which has a single payer system where it's been lauded as the example of how to take care of coronavirus. The situation was that you had a government that took it seriously from the beginning, which was Korea, and another government, which was Italy, that didn't think this was a big problem until it was too late and it overwhelmed the system. So there are two aspects to having a single payer system. One is that if you don't take it seriously enough and do the testing, and you overwhelm the system, that regardless of whether or not you have a single payer system or a fragmented system that we have, you're still going to end up with bad outcomes. And I thought that was very disingenuous for the vice president to use Italy as that example. But secondly, let's look in California, let's look throughout our country where you're starting to see the greatest death tolls. Louisiana and Michigan, those are states where if you look at the people that are dying, they are much younger. They're not the 65 and older population. These are people in their 40s and 50s, and many of them have comorbid conditions, hypertension, chronic obstructive pulmonary disease, diabetes, a lot of illnesses that are not treated well because of the insurance status of this population in those states. So I do think with regard to a Medicare for All system, it may not have changed the dynamics in terms of the number of cases we had here, because you still need a government to take the threat seriously enough and institute testing early enough. But I do think that we would have had a healthier population to begin with, a more robust population, because these are people that would have had preventative care, been better controlled diabetes and hypertension and all of the other chronic illnesses. So even if they got sick, we may not see the mortality rate that we're seeing in those states with very, very sick populations. But if you look at Korea, that has a single payer system, they did everything right. They had testing very on, they learned how to isolate and quarantine people. But more importantly, if people got sick, they didn't hesitate to go get testing. One, they had enough testing, but the government fully paid for it and they fully paid for your care. So I think that the Medicare for All system would have potentially lowered the death rate in the United States. I'm not sure it would have changed the spread of the disease, only because our government wasn't prepared with the testing.
Yes. And Bernie now is trying to get free health care for victims into the next bailout package. Have either of you been following this and trying to observe how receptive people are being? I mean, I find it very ironic that people who voted for Joe Biden, you know, in the races beyond Super Tuesday, 70% of the people in the exit poll said they were in favor of Medicare for All, but they still voted for Biden, who actually said that if it miraculously passed both chambers of Congress, he would veto it. So, I mean, it's very disturbing that they're trying to force, the Democrats are trying to force Bernie out of the race right now when he has the program that is really would meet this moment. So I'm just wondering if you guys are following what he's trying to do regarding this free coverage in the bailout package. And also, you know, to your point about Trump, as usual, like with the TPP, he may actually run to the left of the Democratic Party on this. So who wants to speak to that?
Wendell?
Yeah, I can start. I think what Bernie's proposing is what needs to be done. I mean, we need to make certain that there is some assurance that people are getting coverage for both testing and treatment, regardless of insurance status. And back to what Paul was saying, undoubtedly, a lot of people who are uninsured or underinsured are reluctant not only to get tested, but even if they have symptoms, are probably reluctant to get the treatment that they need. We need to make sure that the public, people understand that they can and should get tested and treated, and that they will not have to, that the government will be able to pay for the care that they get. How that's done, it probably could be, it could be done through and administered through the Center for Medicare and Medicaid Services, not not touching the Medicare trust fund, but it can be done. I think what Bernie Sanders is proposing is what we really need to do. But it needs to be done in a way that we're not letting the insurance companies off the hook, that will enable them to record profits. And they've already signaled to Wall Street financial analysts that they could even come out of this with a net savings, because there are so many elective procedures that are being canceled. If the government picks up a big part of the tab, including for people who have private health insurance, the insurance companies could come out really profiting a great deal.
Well, of course, and that's no accident that the market is up 1,200 points today with this unemployment that people are saying could get to 30%. The stock market is reacting very favorably because of all these corporate bailouts. Now, Wendell, I want to be mindful of your time because I know you said you only had 30 minutes. That's about up now. Is there anything you want to add that we haven't discussed? Because the rest of my questions are directed to Paul.
Just I say in closing that let's not let this opportunity pass without really pressing our elected officials and candidates who are running for office to really address the problems with our healthcare systems in a way that they haven't in the past. We should be holding candidates to the fire and not let a candidate like Amy Klobuchar or Pete Buttigieg or even Joe Biden, for that matter, get away with saying anymore that people like their private health insurance company, health insurance. I would dare any one of them to say that. We need to press them for details on how they want us to move forward so that we're never put in a position like this ever again. Another thing that Paul was saying is absolutely true. We spend also more than $3.5 trillion a year on healthcare in this country, and our results are much worse than they are in other developed countries. Part of the reason is that much of what we spend goes into the pockets of shareholders and executives, and to cover administrative expenses that are unknown in other healthcare systems. We need to make sure that we're not only diverting that money to bring everyone into coverage, but that we have the ability to invest in public health. That's another thing that South Korea and Taiwan and some other countries have done, and why, as Paul said, they've done much better job in terms of lowering or appearing to lower the mortality rate than we have in this country.
Great. Well, thank you very much for being on, Wendell. Stay safe and stay home.
Good to see you, Lauren. Good to see you, Paul. Thank you very much.
Great to see you, Wendell.
Take care. Thank you. Take
Okay.
care. Bye-bye.
Great. So now my question for you, Paul, is let's talk about why ER doctors are being furloughed or their hours are being shortened, thus effectively cutting their pay during this crisis. Specifically talk about the role of private staffing companies owned by private equity firms and how doctors' private practices are pretty much a thing of the past.
So part of what's been so frustrating for me in my 20 plus years of practice is that it became less enjoyable to actually practice medicine because you were constantly on the phone fighting with insurance companies, and the amount of money and time and energy that you had to spend to do that took away from actual patient care. So a lot of doctors, it became harder and harder for a lot of doctors to work by themselves, to have their sole practices. And as a result, they ended up joining groups, and eventually those groups could not stand alone. And those groups ended up being sold to either hospital chains or to private equity groups. And as you know, with either of those, then it is no longer about practicing medicine. It is about you become like an assembly worker that is really has to see a certain number of patients or do a bunch of widgets or rivets in a certain hour. And that's what's happened, unfortunately, with a lot of the doctors now because of the way our healthcare system works. So you do have, it's sort of this paradox that's happening in our healthcare system right now. You have certain areas that are overwhelmed because of the coronavirus. You have ICUs and pulmonary care centers. You have some ERs and hotspots, but then you have other parts of the country where the ERs are not busy because patients are being discouraged from going to the emergency room. A lot of elective procedures are being canceled, whether it be for a colonoscopy or even some types of breast cancer and cancer surgeries. And so a lot of people are idle, not having patients, and this is not allowing them to bill. And if they're working for a hospital chain or a private equity firm, they're not bringing in revenue, and yet they have costs. So a lot of these doctors are then being furloughed as if they were somebody working for another corporation or a Walmart or some other place where they just don't feel they have the capacity. So on one hand, you have a shortage of doctors in the front lines of various situations. Like New York is calling for tens of thousands of doctors to come to New York to work because they're overwhelmed. But then you have other parts of the country where doctors are sitting home or been asked to go home without pay because they just aren't doing any of the elective surgeries. And this is sort of the grossness of the healthcare system. And it really does highlight how doctors have lost all autonomy. If you're not fighting against insurance companies, chances are you are an employee of a big hospital chain or a private equity firm, and you, again, have no autonomy there as well.
Yeah, so I mean, it seems like it's not just a matter of Medicare for all. It's a matter of the fact that the entire healthcare industry is for profit. So do you think that we should go further than Medicare for all and actually have a national health insurance system like they do in England and some other countries? I read an article recently about AOC and how, you know, she let go two of her more radical staff, one of whom was Corbin Trent. And they said that she had been floating, or they had been floating to her, the idea of proposing a national health insurance, a national health care system. And I can vouch that that's true, because he asked me what I would think of it, and I forwarded it to you. And this was months ago. And I also forwarded it to the head of the National Nurses Union. And we talked about how this would be a heavy lift politically. But I mean, basically, do you think that that's really what we need in this country?
It's not clear. So a couple things. If you talk about a national health service, very much like the United Kingdom has, that is truly socialized medicine, where the government owns and operates every aspect of the healthcare system. They own the hospitals, they own the pharmacies, the radiology equipment, the labs, they employ the doctors, the nurses, all of the technologists, the phlebotomists, the respiratory therapists, the cleaning staff, everything. It's all contained. And we actually have that system in the United States. It's called the VA system, where the government owns and operates all aspects of that. I think that is definitely a much, much harder sell, because I do know a lot of doctors who long for the days where they could hang up their own shingle again, get out from under the big thumb of a big hospital regional chain that has bought the primary care practices or private equity, and they'd like to start working for themselves. I think a lot of those doctors are supportive of a Medicare for all system, because they would still maintain some autonomy, but you would have a single insurance entity that would be run by the government. I do think there could be some doctors that are open to a more socialized national service, but I think that I would say that the appetite for that is far less than the appetite for Medicare for all. I think it's hard enough for us to get to Medicare for all without people calling it socialized medicine. But if you tried to take it truly to socialized medicine, I do think that the polling on that would not be as favorable among physicians and healthcare providers as it is for Medicare for all.
Okay, now, before you talked about canceling elective procedures. Now, I've read that they're calling cancer surgeries elective procedures, and people are kind of freaking out about this. Can you speak to why they consider life-saving surgeries like cancer surgeries elective? And is there any push to try to do something about this?
So it's what I would say this, there are, look, I think as an oncologist, I think all cancer is serious, and I think that it should be addressed as soon as possible. But the examples that I've been hearing are things like a breast cancer that may be sensitive to hormonal therapy, that you could put someone on a drug like tamoxifen for a couple of months that could cause the tumor to either stop growing or to shrink, to buy some time. The second thing is some prostate cancers tend to be much slower growing than others, and you could potentially wait there. But I think it is very unnerving to tell somebody who has a tumor in their body that we're going to wait to take it out or to address it. So I think part of the problem is the hospitals have felt that anything that ties up their ERs, that if, God forbid, the patient had a complication and ended up on a respirator, that's one less respirator that you would have available for the COVID-19 scare. But I do think that there needs to be a way to have more outpatient surgical procedures for these types of early stage breast cancers and such, that perhaps you could still limit the liability of using up an ICU or a respirator situation. It is something that I think, because again, this has all happened so fast that it's constantly evolving. And I think initially we went so far to stop everything, but then I think you're starting to see some slow trickle back in of cases based on how emergent the need is. But there are, the fact is, there are some cancers that are very, very slow growing that could be treated with non-surgical measures for a period of time until you could really free up all the ORs again.
Okay, now I watched a really good CNN special last night on life in the OR, and they were focusing on the SUNY State University of New York Downstate Hospital in New York City, where they showed they have a shortage of beds, they have a shortage of doctors, they have a shortage of ventilators, they have a shortage of PPEs, they have a shortage of sedative and pain-killing medication that they need to give. This morning on Democracy Now!, Amy Goodman was covering the strike outside of a hospital in Harlem. The nurse who organized the strike was saying they're being asked to wear their masks for 60 hours straight. How does it happen that in the richest country in the world, we've gotten to this situation? And do you think, because you're here in California, how well prepared are we for the peak in both California and Los Angeles?
So let's start with the first question of how did we get there? Again, I think right now is not the time to do a lot of finger pointing, except to say that this has been a colossal failure by many, many levels. You have people in the federal government that maybe didn't take this seriously enough in the beginning, but you also have people on the state level who didn't take this seriously. So I think right now we all need to pull together, get everyone through this, but afterwards we need to have a real postmortem analysis that is doesn't spare anyone, because there are a lot of mistakes across the board. But if you look at the supply chain and how that's carried out, most of our equipment that is used in the hospital is produced overseas. And then you have a handful of sort of brokers that have gotten these sort of lucrative contracts that are the only way that a lot of these pieces of equipment can come into the United States and then be distributed to hospital chains. They're sort of these prime middlemen who make a lot of money, but have paid out a lot of money on the other end to get the exclusive contracts to distribute this. That's something, again, that is all too true about the fact that we've offshored most of our manufacturing for everything, not just medical equipment and pharmaceuticals, but everything across the board. So that needs to change. And I do think that this has got to make us less vulnerable in the future, because the COVID-19 scare it will dissipate, but there's a chance this is going to be with us in perpetuity. It's just going to become seasonal. So we need to be prepared for that. So that's one. As far as California, I will say this, Gavin Newsom, our governor, was one of the first governors to institute a home sheltering policy well before we had any of the caseload that you saw in New York and elsewhere. And it really is working. I think Californians, for the most part, have taken this very, very seriously. And as a result, you're seeing a real bending of the curve. So prime example, there's a COVID-19 database that's constantly updated every week. And what you're seeing is that the projected, both in terms of case numbers and deaths, has rapidly decreased from what they initially thought was going to happen. Now, the total number of cases is very misleading because our state is still not up to par in terms of being able to offer tests to everyone who needs it. There's certainly been people that have died in the last month who were not tested because the feeling of why waste a test on somebody who's already expired, that probably have not been counted in terms of the total number of deaths from COVID-19. But what we can see compared to other states is, as many people as we have in our states, our death rate per 100,000 is minuscule compared to what you see in New York, Michigan, Louisiana. And this is really attributed to social distancing. The idea behind social distancing is that you don't eliminate all of the cases of infection, but rather than overwhelming the system and have a huge number of people go to the emergency room all at once, by doing this and limiting the contact, you're going to spread out this and greatly diminish the spread of the disease and lower the rate of that so that you still have respirators available. And today you saw Gavin Newsom, who was confident enough to send 500 ventilators from the state of California to states who needed it. That should tell you something about what his people are telling him in terms of the numbers. We're not out of the woods, and I think you're going to see a lot more death here in California in the next 10 to 14 days. But compared to where it should be for a state as populous as ours, it's dramatically lower than what it should be. So I think we are in a good shape as long as we as a state continue to take this seriously, do our part. But this is really kudos to the governor for being really out there, even before Governor Cuomo or any of the other governors instituted this.
Yeah, I had that feeling myself, and I watch his press conferences. I watch Garcetti's press conferences and even Trump's press conferences. Yesterday, Trump was he was beyond his usual idiocy when he was talking about this chloroquine. Today, Swedish hospitals have stopped using it because it's showing severe side effects, adverse side effects. And here he is telling the American people, with Dr. Fauci and Dr. Blick standing right next to him, that, oh, you might as well try it. If you've got it, why not try it? And it's actually dangerous. And they interviewed somebody last night on CNN who said that if it's not FDA approved, there's a reason why you have to get FDA approval for something to treat something else. I mean, this was developed for malaria. There's also another drug, I forget the name of it. I think it begins with an R, that was used for lupus.
Remdesivir.
Yes, lupus and rheumatoid arthritis. And it was shown that pharmacists are, stockpiling this, pharmacists were saying that doctors were prescribing this and stockpiling it for themselves, and lupus and rheumatoid arthritis patients aren't getting it. What can you say about the latest developments in testing, treatments, and a vaccine?
So let's first talk about the testing situation. There are two types of tests that are available right now. One is where you do a swab that many of your viewers have seen. It's quite invasive. They stick a swab deep up into the nasal cavity, and then it can take a day. Sometimes some labs have taken up to a week to get the results back. That is a PCR, a polymerase chain reaction based RNA test that looks for presence of that virus in the system. And that is by far probably the most accurate test at determining somebody has an infection, although I've been reading some alarming reports of false negatives where patients who clearly have the disease and even have died turned out to be testing negative. So there may be some issues with that, but that is by far the more sensitive of the tests, but does take time to get that back. And it's taken time for a lot of labs to offer that. The second test is something that is becoming validated right now, which is a finger prick test where they take one drop of blood. It's kind of like testing for blood sugar. You put the blood on a cartridge, and within like 10 minutes, it will tell you whether or not your body has the antibodies to the coronavirus. And the idea is that if you have antibodies, that either suggest that you were exposed to it and have recovered or are currently infected right now. The idea of how we would potentially use this test is for people who want to go back to work, who have thought they had it. You can do the test. If they test positive, you have them wait another 10 days. If they show no symptoms, then you can release them back to work. This is the idea of doing targeted direct releasing so that you can reintroduce people back into society that maybe you feel have developed an immunity and are not at a risk of infecting others. So that's where we are right now. As far as where we are in terms of the vaccine, there are many, many companies that have vaccines currently in clinical trials. The earliest any of them will be available is probably in another 14 to 16 months. Maybe a little bit sooner. You had Bill Gates announce that he's going to commit several $100 million to start building the factories for 7 viable candidates. The idea is that even if only one of those 7 turns out to be really successful, that the production will begin beforehand so that we should have enough supply to treat as many people as possible with the coming season. And that's credit to Bill Gates for doing that. But the vaccines will take some time. The other thing about vaccines are, so far, when they've been carefully following the virus, because they've been able to sequence it, it's not mutating nearly as fast as the flu does. In fact, it's mutating very, very slow by virus standards. And the feeling is that whatever vaccine that's being produced right now will be effective regardless of the mutations that occur over the next year in this virus. So that's actually some very good news. The final thing is with regard to treatment. This is a very tricky situation. So, you know, I think that the president, he's not a physician and he's out there touting treatments, but at the same time, I think that I find people are a little too critical of this as well. So the World Health Organization is doing 4 international trials right now looking at various treatments for the treatment of coronavirus. One is remdesivir, which is a drug by Gilead. Another one is using hydroxychloroquine, which is what you mentioned. There's another that are using 2 HIV drugs, and then the third is using some immune cytokine support. So let's just talk a little bit about what I've been hearing on the front line. So I have a lot of my friends who are colleagues who are on the front line taking care of coronavirus patients. And they found supportive care is not working in patients. Now, for healthy people like yourself and others, you may not need anything other than to take medication to control your temperature and aches and pains. But for those that are rapidly deteriorating, my friends are saying they're left between a rock and a hard place. What do they try? They have to intubate these patients and nothing is working. So a large percentage of my colleagues will tell you that they have tried either remdesivir or if they can get it and if their hospital has availability, even though it's not proven, or they've tried hydroxychloroquine in combination with Zithromax. And I can tell you that it's not working for everyone, but a lot of them do report having, of the available drugs, that's the one that seems to have shown the most promise up to now. Now, having said that, I'm not recommending that everyone go and take these drugs if they feel they're getting sick. That's not what I'm saying at all, because the drugs do have side effects, as you mentioned, the Swedish study. Most notably, hydroxychloroquine can cause fatal arrhythmias, which is something that can really cause death. But I do think that we shouldn't be so politically charged in. If anyone but the president had said that, I'm not sure we would have the outrage that we have about him using that. The doctors in the front line will tell you that it's not working on everyone they give it to, but at the same time, it is better than nothing for a lot of the patients that they've seen some improvement on. So I think in the next 3 or 4 weeks, we're going to have much more data. And we're going to see some treatments that are effective. It's not going to be effective for everyone, but I do think we will start to have 3 or 4 drugs that are out there that can work, and people are going to be more apt to get them with data behind it.
Okay, now you're a biotech exec. I sent you an article from Zero Hedge about the San Francisco biotech exec who was featured in the Netflix documentary Pandemic, he announced this week that he and his team may have a cure for coronavirus, which is headed to the US military for testing. And you're going to understand this, I don't. We have generated extremely potent picomolar antibodies that block known neutralizing ACE2 epitopes, blocking the novel coronavirus from infecting human cells. What do you know about that?
So, I mean, it is one of the approaches. So the reason the virus gets into your nose and down into your lungs and why it has such an affinity for that is the way it gets into your body is through these angiotensin converting enzyme receptors. That's the ACE receptor. It's sort of the attractive sticking point for these viruses, and they use those receptors as a way to get into your system. So what he's established, from what I can tell, is antibodies that basically will bind to those receptors, and when they do, it'll further prevent the virus from binding to those receptors, and they can't get into your system. I certainly think it is one area that potentially could work. My concern with any time you have an antibody that blocks a normal receptor, remember these receptors serve normal functions in our body. And if you block their normal function, could you cause an untoward side effect? I do think that, again, that this is a disease that may behave differently in you versus somebody who has diabetes versus somebody who has chronic obstructive pulmonary disease, who's frail or weaker, so that there may not be a magic bullet that works across the board for everybody. I think that it's better to have as many weapons in our arsenal as possible. And I think that a lot of the drugs that I mentioned could be part of that. But that I think that the reason you're seeing mixed results with some of these initial trials is it's a very heterogeneous population. And so until we get big amounts of data, we really won't know for sure. But I do think that you'll see all of these treatments that have been touted having some role in this disease moving forward.
Okay, well, it's apparent to me that the best thing that we can do is keep social distancing, or actually we should be calling it physical distancing, because we're all socializing here. We're just doing it on the telephone or by Zoom meeting or FaceTime. My final question to you is about the Imperial College study, which spooked everybody last month when it was released to start doing these really strict stay-at-home orders. What I got out of that is that until we develop a vaccine, which could be 12 to 18 months, we really should be keeping up these practices, because in the countries where they flatten the curve and they started to let people go out again, the cases have gone up. So, I mean, do you really think that, Trump talks about opening up our country, he's talking about the economy. I don't see how the economy can survive if we have to stay home for 12 to 18 months. So do you think some of the things that you referred to before, like, this testing to see if people have antibodies to it, or if having the disease itself makes you immune to it, do you see any way that we can open up the country selectively before 12 to 18 months when we have a vaccine?
Yes, but under the caveat of two things. One is, once we have really, truly unlimited testing capability, then I think that would be one of the potential things that we can do. So let's say this. Let's say in the next 2 months, we get a handle on the situation. Every state flattens its curve. A lot of the states that have not instituted the home sheltering do not have the outbreaks for maybe not having dense populations or whatever. They're lucky, and we don't get this reinfection rate and then some sense of normalcy. The key is this, that next time when this happens, that we can have vigorous testing from day one so that we can start to identify who's sick and quarantine them immediately before they continue to go out and infect people unknowingly. So I think that we need to find a way to distinguish those people that have been exposed to it, who have the antibody, who are not going to get it, and allow them to return back to work to try to rebuild our economy. But I don't think we're anywhere near that yet as a country. And even in California, with our positive effect that we've had, if we were to just stop this in the next 2 or 3 weeks, I think you would just see explosion of cases. So we have to first make sure that we get this case down to where it is very, very negligible, and where we can keep track on those people that are infected so that we can reduce the spread. Now, once you have effective treatments, once you have an effective vaccine, that's where I think you'll see much more normalcy return.
Great. Well, Paul, I want to say I feel so grateful for you and all your fellow doctors who are really, on the front lines of this. I mean, I know you're not treating these patients, but the amount of work that you're putting into, consulting with people, getting the information out, advocating for Medicare for All, which we really need. I just want to thank you and ask you if there's anything more you want to add before I let you go and promote my upcoming shows.
No, just to say thank you for all that you're doing, and I hope more people will tune in and support your show.
Thank you. Please share it. All right. Take care, Paul.
All right. Thank you.
All right.
Thanks.
So everybody, I am going to be doing a show tomorrow with Zach Carter, who you may read. He is the economics reporter for the Huffington Post. And he did an article after the last bailout package that was entitled, "The Democrats Are Handing Donald Trump the Key to the Country." So we're going to be talking about exactly why that bailout package was insufficient, what they're talking about in the phase 4 bailout, and how we can lobby our representatives to make sure that it helps the people more. People are really struggling with not being able to pay their rents, with losing their jobs, with the backlog, getting unemployment insurance. There's a lot of actions that I've been promoting that people are doing to get a rent freeze here in Los Angeles. There's a city council meeting tomorrow that people are being asked to share their stories and make public comment. Nuri Martinez, the president of the Los Angeles City Council, was protested by activists from the LA Tenants Union last night. I wish they told me about it. I would have gone to live stream it. They did a car protest, and actually people even got out of their cars in front of her home with a bullhorn, because she is the president of the city council and led the opposition to freezing the rents. And she also is a landlord. So Wednesday, I'm going to be having on my show Dr. Lara Fielding, who is a clinical psychologist and author of the book Mastering Adulthood. She uses mindfulness and CBT to treat her patients, and she's going to be talking about how we can cope with some of the uncertainties and the economic pressures that come in a global pandemic such as this. On Thursday, I'm going to be having Leonardo Flores, who I've had on my show before. He is the Latin American coordinator for Code Pink. He's going to be talking about how Trump is using this to try to start wars with Venezuela. Basically, they've declared Maduro a narco trafficker, which is absolutely outrageous considering all the trafficking is coming out of Colombia. And I'm also going to ask him to address the rumor that Trump is going to be using this to start a war with Iran. We know that we've been begging them to remove the sanctions on Iran. They have a terrible outbreak there. People are dying in droves in Iran. And we have to be paying attention to our foreign policy, even as we are dealing with this crisis as it affects us at home. So I hope people will share this show and tune in and watch my other shows. If this is the first show that you're seeing, I do it live here on Facebook, then I upload it to my YouTube channel. You can also follow me on Twitter at Lauren_Steiner. So until you see me next, stay home, stay safe, and keep fighting.